So Filip is the manager of infectious diseases, sexual health, and the Brant IPAC satellite hub, a role he's held since 2020. He's also previously served as the manager of environmental health. Filip began his career as a public health inspector, specializing in infection control and infectious diseases, and has worked in acute care as an infection control practitioner before joining Grand Erie Public Health. He is both CIC and MDR certified and an advocate for all things IPAC. Filip is also a part-time professor at Conestoga College, where he teaches in the IPAC certificate program and has previously taught in the Global Public Health program. So welcome, Filip.
Hello, everyone. Thank you again for all coming to this event. It's lovely to meet some of you as well as see some of you again. So today I'll be talking about antibiotic-resistant organisms. I know, a very, very fun topic. So just a little bit about the agenda today. The 4 AROs, or antibiotic-resistant organisms, that I'm going to speak about are MRSA, VRE, ESBL, and last but not least, CPE. I'm also going to dive into what does the screening look like for acute care, long-term care, Tylenol, and CLS. What does routine practice means in the world of AROs? What does additional precautions mean in the world of AROs? And lastly, what are some resources that are available to you that you could use to just feel a little bit more comfortable when you are identifying a positive antibiotic-resistant organism in your facility? So what are AROs? So these are germs that have developed resistance to the action of several antibiotics that are making them very difficult to treat. So I said a bunch of acronyms, but the actual names are methicillin-resistant Staphylococcus aureus, so that's MRSA, vancomycin-resistant enterococci, which is VRE, extended spectrum beta-lactamase, which is ESBL, and last but not least, carbapenemase-producing enterobacter CA, which is CPE. It's also really good to distinct between what is colonization versus infection. So sometimes you may be seeing somebody who's asymptomatic, you might not actually know they're colonized with an ARO until they get tested, which can cause obviously a problem because it can spread. And then the infection side of things is obviously if somebody is has symptoms. So what are some challenges of antimicrobial resistance? It can cause delays in initiating appropriate treatment, especially if you have not been aware that somebody's positive until later on. It can prolong hospitalization and also increase healthcare costs due to that. It also has major contributors to hospital-acquired infections, especially with MRSA being the top leading ARO. We also see a higher morbidity and mortality. The next one's quite interesting, and this one is a topic that I've been learning a lot more, and it's the resistance and spreading rapidly through horizontal gene transfer. So what is horizontal gene transfer? So especially in some gram-negative antibiotics like antibiotic-resistant organisms like CPE, it can quickly, through horizontal gene transfer, actually through the plasmids, transfer one organism to another. So the plasmids are small mobile DNA molecules that can carry carbapenem genes, which break down powerful antibiotics. So these plasmids can move between different bacterial species. For example, an E. coli can then turn into a Klebsiella pneumoniae organism. This means the resistance can spread much faster than through random mutations alone, making outbreaks harder to control in healthcare settings. So understanding this really helps why strict infection control surveillance is critical, especially screening alone. Once a plasmid enters a bacterial population, it can also propagate widely and rapidly, which is why it's so dangerous. And lastly, we're seeing evolving faster antibiotic-resistant organisms rather than the development of new antibiotics. So what are some ARO risk factors? Exposure to a healthcare setting, really any, could be a risk factor. Longer hospital stay, or if you've had a resident that's been at your facility for a long period of time and they just have not been maybe tested, any kind of invasive medical procedures or devices, intensive care needs, severe illness or comorbidities, use of antibiotics or antifungals, contact of a confirmed case, so if they've been identified as a contact of someone that's positive for a certain ARO, and then lastly, if they themselves have had a history of ARO, maybe you have cleared it, but potentially could be colonized again in the future. So MRSA is probably one that you're relatively familiar with. It is methicillin-resistant Staphylococcus aureus. Staphylococcus aureus in general is a common bacteria that can live on our skin, and actually in mucous membranes for about 20% of healthy adults. And it is a leading cause of hospital-acquired infections. Some common symptoms, just as you can see on the picture, it can cause redness and inflammation in an infection site, pus or other drainage, as well as fever. If you do obviously see this, I would say next step would be to swab that area and to see what is actually potentially growing there. Next is VRE. So this is more of an environmental-based antibiotic-resistant organism. It is part of the Enterococci family, and it does live naturally in the GI tract. VRE are strains that have become more resistant to vancomycin, and they can colonize in wounds, ulcers, and medical device sites as well. And a majority of them, they actually don't show signs and symptoms, so they can be asymptomatic. And sometimes facilities typically might not relatively do universal screening for VRE, typically for MRSA, but for VRE sometimes depending on the facility and the costs, they might not do VRE. Next is ESBL. So this is an enzyme that inactivates the beta-lactam antibiotics, which are typically common used antibiotics. They often colonize also in the GI tract, but the lower GI tract. And they also have producing bacteria like E. coli, Klebsiella pneumoniae, and so on. And routine screening is based on local epidemiology. So if you're seeing an increase in potential ESBL outbreaks, you may want to start to think about screening this for this when someone comes into the facility. So next is CPE, and this is really the superbug of the antibiotic-resistant organisms. It was primarily travel-based, I would say about 10 plus years ago, and now it's becoming more and more endemic in Ontario and in our healthcare settings. So this is, I'm just going to go over some terms and then kind of just share what CPE is. So it is part of the Enterococci family. It is a gram-negative bacteria that is also found in the GI tract. Some examples of these bacteria are E. coli, Klebsiella pneumoniae, Enterobacter species like E. cloacae, and then some ones that are not as common, like Proteus and Citrobacter species. Carbapenems are types of antibiotics that, some examples include imipenem, meropenem, and ertapenem. And carbapenemase enzymes, so some of the ones I want to highlight are NDM, OXA48, KPC. So these three, I would say, are more pronounced in North America and Canada and the United States. And then VIM and IMP are ones that we typically don't see here as much, but they could be found in other parts of the world like Israel, Greece, and South Asia as well. So CPE, all of those kind of terms put together, are bacteria in the Enterobacteriaceae family that produce an enzyme called carbapenemase, which inactivates carbapenem antibiotics, making the bacteria highly resistant. And the reason why it's so dangerous is that serious infections have been associated with 50% plus mortality rates. It can also spread rapidly in healthcare settings, as it is also another environmental aero. So as Francine mentioned, it can live in sinks and drains. It is very difficult to get rid of if you don't have the proper disinfectants at your facility. The main reservoir is also colonized patients, residents, and clients, and prolonged colonization, because with CPE, a lot of times somebody's colonized for a long time, you don't take them off of isolation. And when that happens, about 16.5% of those result in infections. So if you can just all take your phones out, we're going to do a little quiz. Yes. So there's a QR code that you can scan, or you can go to https://forms.office.com. There's that little naming convention, but I think the easiest way would be to scan the QR code. So while you're scanning it, I'm just going to go over the first case scenario. So you have a resident that returned to the long-term care facility after a 2-week hospital stay for treatment of a urinary tract infection, and they have minor complications. A routine admission swab at the hospital detected MRSA. The resident has shared a room with another long-term care resident for several years. The resident is currently asymptomatic and had no previous history of MRSA colonization. And what is your first step in managing this? Is it working for everyone? Just give me a thumbs up. Not, I can go over the multiple choice and then we can go over them together. So A is initiate contact precautions for the positive MRSA resident. B is order nasal rectal swabs for the roommate. C is transfer the resident to the hospital for MRSA management. And D is disinfect the resident's room. So how many people say A? Can I say show of hands? So a couple A's. How many people say B? No one. C. And last D, show of hands. So it is actually A. Sorry, just some technical difficulties. Okay, we're just gonna go and move forward. So it is A. It is initiate contact precautions for the positive MRSA resident. And the reason why this is so important is because as the person is coming back to your facility, you want to make sure that you're obviously placing them in contact precautions and that you are making sure that any staff that are entering the room, any visitors, are wearing the appropriate PPE and doffing the appropriate PPE. Some of the other ones, so you could order nasal rectal swabs for the roommate because then they would be a contact of that case, so that's something else that you could do. Transfer the resident to the hospital for MRSA management. So it sounds like this person is colonized, so maybe if it was an infection, they may need to get treatment, they may have to go back to the hospital, but it sounds like it's a colonization. And then lastly, disinfecting the resident's room. So of course, anything that they've touched, you want to start to think about like dedicating equipment, like if they don't have their own washroom, making sure that you are dedicating commode chairs, BB cuffs, and so on. And then if you can't, then cleaning and disinfecting of those reusable items in between use of residents. And then the next scenario. Oh, sorry. So the next scenario, again, sorry about some technical difficulties, but it is a case study on a CPE case. So the case study is a 75-year-old patient who had been hospitalized for 6 weeks following a complicated hip fracture developed a sudden fever and low blood pressure. The patient had received multiple courses of antibiotics during their prolonged stay for various secondary infections and wound care. On assessment, they appeared weak and confused, but no clear source of infection was found on examination. The blood cultures were subsequently grew CPE, confirming a bloodstream infection in this case. So, what are your first step in, what infection control measures should be implemented for a positive CPE patient? So A is place the patient in a private room. B is place the patient in contact precautions. C is cohort them with other CPE positive patients. D is testing of sinks and drains followed by regular cleaning and disinfection. And E is dedicate shared equipment or clean and disinfect routine use. So with this one, you could have multiple responses. Can I have a volunteer to maybe share their thoughts and which ones you think are correct? Anyone? Yes? Yes, you got it. So all of these apply. I think the only thing with CP is you have to be very careful with cohorting. The person has to be with the same organism and the same gene. So a lot of times it can also be dangerous because you could give, even though they're both CP positive patients, you could potentially transmit different type of gene or CP organism to the other patients. You have to really be careful with cohorting. So it should never really be done unless you're like at a last resort. So next, we're past the technical difficulties. We're going to go into some ARO screening. So what should your screening questionnaire include? And this is so important to make sure that you're capturing potentially colonizer infected people coming into your facility. So really looking at the prior history. Has there been any previous colonization or infection with an ARO? Looking at healthcare exposure in general. So have you been admitted in a healthcare facility for more than 12 hours in the last year? And this also captures outside of country as well, not just within Canada. And then if they've been transferred to another home, like a long-term care home or potentially an acute care setting, they're coming back, making sure that you're also screening them and swabbing as well. If they've been in contact with a positive ARO, or if they've been part of an ARO outbreak, that's another question that you want to really make sure you're including, as they would be seen high risk. And then lastly, for high-risk medical conditions and procedures, so if they're on hemodialysis, if they had a scope procedure, like endoscopic procedure recently, any surgery or indwelling devices like central lines or urinary catheters, those are also some risk factors that might want you to, prompt you to start to obviously test them and investigate further. You're interested in reading more specifically about CPE and screening in healthcare settings. I did publish an article that is focusing on acute care and long-term care facilities, and there's some trends that showcased in terms of like what are some screening questionnaires that a lot of the facilities typically included, so you can find that there. So next is immediate actions for resident and patient if they fail the screening. So if they're identified at risk, what are your next steps and what should your policy include? So the first thing would be implement those appropriate isolation requirements and really do an assessment of what does that look like. Is it contact precautions? Is it droplet contact? And I'll speak a little bit more about how it may be droplet. Collecting specimens. So for MRSA, you want to do the nares, perianal, skin, and wound swabs, whatever is applicable. For VRE, ESBL, and CPE, stool is typically preferred, but you could also do urine or rectal swab. And then lastly, if you have a ARO outbreak, you want to make sure you are also introducing point prevalence testing. PHO is a really great screening tool that you can actually access. I think it got published last year. There's a link to it in the resources section, so I'll share the slides, but feel free to use that as part of your screening tool for AROs in your facility. And how are AROs transmitted? So either through direct contact or indirect contact, and that stays true for all of those 4. So direct contact is usually skin-to-skin contact. So some examples of this would be contaminated hands of healthcare workers or potentially residents and patients. For indirect contact, it would be touching contaminated surfaces and equipment without cleaning and disinfection in between. So some high-touch surfaces or some equipment that could be a vector for this would be doorknobs, BP cups, thermometers, glucometers, and bed rails. Francine spoke a little bit about routine practices, but this one is also part of ARO prevention as well. So you want to make sure you're doing that point of care risk assessment. If you're looking at the signs and symptoms, is this someone's baseline? Knowing colonization or infection status of the resident or patient that you are taking care of. Is there any presence of any wounds, invasive devices, or any draining bodily fluids? And also you want to make sure you do an assessment in terms of the type of care or procedure that's being performed. So potential for exposure to blood, bodily fluids, secretions, or contaminated surfaces. Well, in that case, you might want to consider implementing PPE as part of your care for that patient or residents. Hand hygiene is also very, very important, making sure you're following the 4 modes of hand hygiene, and you also have access to alcohol-based hand rub readily when you're entering the room, as well as when you're exiting the room, if you're doing any kind of movement 3s as well. And environmental cleaning, so really looking at all of your disinfectants that you have in your facility and are they effective against the ARO that you're trying to deal with. So CP again is a super bug, so you might want to consider using different types of disinfectants, but it's also a really good time to kind of do a check and is my disinfectant Health Canada approved? Is it expired? Are my staff following the contact time? And are you using it as the intended use for that disinfectant as well? And lastly, just safe handling of waste and linen. So this also plays a big role of how are you getting rid of any waste, what are your processes for laundering as well. Next is additional precautions, and this is where kind of the droplet contact side of things come up. So this is a reminder that this is in addition to routine practices, so you really want to assess the risk. And one example is the patient on a trach, and are they colonized in the trach for an ARO? In that case, are they coughing? Are they, they don't have any kind of respiratory symptoms, or maybe when you're doing suctioning, like what kind of PPE should you be wearing? So really doing that assessment, and maybe sometimes you might have to go above that contact precautions for AROs as well. So really thinking about that. Posting isolation signage. So for when you have someone in additional precautions, you want to make sure there's a clear isolation sign posted at the door indicating what kind of PPE someone should be wearing. Making sure that you have a clean supply of personal protective equipment that is not in someone's room and a place that you can store it in a clean manner as well. Next is dedicating equipment. So I mentioned commode chairs as well, but yeah, if you have an ARO positive resident or patient and they're sharing a room because there's no privates available, you want to make sure that you're dedicating that commode in case there's no access to a private washer. And enhanced cleaning and disinfection. So when you are having additional precautions, you want to maybe look at more disinfection in high-touch surfaces, really making sure that your EABS staff are involved as part of that assessment as well. It is a multidisciplinary team at the end of the day in terms of IPAC. And some other considerations to think about. So environmental testing, especially if you have an outbreak, you want to look at potentially testing your sinks, your drains. As part of any kind of outbreak, ATP testing is really important as well, just to see if environmental cleaning is effective during that outbreak, and maybe that's the part that you really need to kind of hone down on to be able to get the outbreak to kind of control it more so. And then conducting audits, so hand hygiene audits, PPE audits, as that IPAC lead, that is your responsibility. But I also think that it's important to pick IPAC champions in your facilities and try to really empower them to be able to take on those roles as well. And lastly, just some resources. So if you want to go to the HNHP IPAC Hub website, you have different bugs of the month. So there's actually all the arrows are on there, as well as some other ones that you can find at the booth over there. There's an antibiotic-resistant organism risk factor screening guidance for healthcare settings that is also a great resource to use. So that's the one that I had in the earlier slide. There's an evidence review and recommendations on VRE for healthcare settings from PHO that you can access. The main MRSA, VRE, and CP pages in the PHO website. So if you're curious to have some information on your huddle boards on how do you test people for using arrows, or what are some signs and symptoms to look out for, those are really great pages to take a look at and maybe post on your huddle boards as well. And then lastly, there's a new IPAC course for healthcare workers that is posted on the PHO website. So if you want to engage your staff in doing those modules, I do think it's a really good kind of basic training for IPAC that can go beyond the IPAC leads. And then we have some time for some questions. Any questions? Yes.
Sorry. Thanks. So since CPE became publicly, I guess, reportable through long-term care for screening for long-term care homes, are you finding that you have the resources you need to develop policies? Are you finding it challenging? I know that a lot of times you will come up with a case accidentally. Maybe they are asymptomatic, but have been admitted to the hospital and are screened and come back positive for CPE, or vice versa. Maybe they're a brand new admission to your long-term care facility, and that's how you find out. And I know that there are a lot of questions and a lot of practice changes, especially with this new bug. So I'm just wondering if are our long-term care homes finding this new addition, or have you been lucky enough not to have any cases yet? Anybody wants to share?
Oh, I'm not long-term care, but
Do you want to make?
I'm not long-term care, but we have recently had a contract payment with CPCs. They have been, now they don't no longer have to do this organized or whatever. But it was doing a lot of research, a lot of cleaning and doing all that research before we actually implement all of these cleaning processes for us.
And what facility are you with?
I'm with Able Living.
Oh, you're with Able Living. Okay, so you're probably like, well, with the hospital-based or congregate living setting.
First one we have.
Yeah, okay. Thank you for sharing. I imagine that you probably are not the only one, but it is probably a challenge. Obviously, the IPAC Hub and the health unit are here to support you all, but I just thought that was an interesting bug. Since we don't really know that much about it yet, or because we know a lot about it, but we haven't come across it a lot.
Yes, Francine?
Right. Right.
So I take 115.
We ain't screening for it. Oh, you're not screening for it. Okay.
No, we're not.
Okay, so I'm wondering how.
And I can maybe speak to like that research study I spoke about. So we definitely saw a big difference with hospitals screening for CP, and a difference in long-term care homes actually screening for it. So that's one thing that I knew before kind of starting the research that potentially can come up, but I was able to also show that with some numbers. But with that, I also was able to see that there were some challenges from the long-term care standpoint in terms of funding and staffing. So those are all big topics in terms of when you are trying to do screening for arrows, and what does that mean for the organization from a cost perspective as well.
So I have heard of medical directors that are not even supporting screening for the area of emergency. So this isn't a very little secret. We use health space thing. This is a recommendation that we are screening for CPE in our homes. We're not doing it, and that's okay. This is what I'm saying. What we do know, we get this information from hospitals on admission, which is really important for us to know. Then we're able to assess how that admission, see whether or not we have the ability to keep that person or have that person come in for. They meet the criteria for IPs just flip on its hip and start screening the same people. We don't have the capacity to meet the needs of that individual resident. Now, if they're able to be efficient, then we know the individual has them. We have the resources to be able to care for them. Move that all. But dirty little secret, we're not doing the screening. It's not a requirement that we do this. We don't do it as well.
Thanks for sharing, because it is, I think a lot of people are quite overwhelmed with it, especially since it became a direction for long-term care homes. But yeah, it is very research.
We see PSBL far more than we see CPE. Scientific. And again, it really is about learning as IPAC specialists. What would we do in the event of? What would you do in the event of? So if I could make a suggestion, a health unit in hub